I'm going to stop talking about us and turn it over to our presenter today now. So Robin Durham is an assistant professor of social work in the MSW program at Concord. She was hired to teach there in 2018, but before that, she practiced as a licensed independent clinical social worker for over 30 years, providing therapy in outpatient settings as well as community health including community health, school-based health, and private psychiatric clinics. She also served as the adjunct faculty for the Concord Bachelor of Social Work program for several years. She is a National Association of Social Workers member and has been served on the West Virginia NASW State Board of Directors as a regional representative and president. She is also working towards her DSW through the University of Kentucky and provides clinical supervision to social workers seeking LICSW status and continuing education programs. So we are very excited to have her back to present on this topic, and I'm going to stop talking and turn it over to her.
Thanks, Mary, and thanks, Sarah, for setting all this back up. What I want to do with this, I don't know how many of you are joining just for the ethics hour, which is fine, but this is really going to be focused on clinical supervision for like potential LICSWs. So as Mary mentioned, if you have a question, either just say it or put it in the chat, and I don't mind to be interrupted to talk about it. Okay, so let me get this on share because I always forget to do that. People are like, we're not seeing it. Okay. Let's see. I can see some of you at least. Okay. All righty. Let me just say as a disclaimer, I'm not going to claim that I'm an expert on this. I've done a lot of clinical supervision, and I will tell you it's really a learning process. The more I do it, the more I read about it, the more I learn, and sometimes cringe at what I didn't know. So one of the things that I know I'm working with Vicki James at the board with is really trying to clean up the process. We are working on kind of a clinical supervision manual that will help hopefully provide some guidance on what you need to do, some considerations, things like that. The other thing is I'm finding out, being in this program I'm certainly with people all over the US, and how different clinical supervision looks in every state. I know one of my colleagues in Texas, they can have 6 people in a group, but unlimited groups for clinical supervision. And that makes me feel kind of all kinds of ways about that. I'm not comfortable with that, but that's me. Okay. So to kind of get started, I'm not going to read through all these. You're going to get them. We're going to talk about it again, but one of the main things I want us to understand, and you'll hear this more than once, is clinical supervision is very different from licensing supervision. They're both important, and they're both important for different ways. But as you'll hear, and if you may already know this, clinical supervision carries a lot more liability with it. It carries a lot more responsibility in a lot of ways. So I want us to be thinking about that, and that's what I'm going to talk about as we go forward. Just kind of brief objectives, what we're going to talk about. Okay. I found this quote earlier this year, and I just love this because I think it is very true. We think of it as being, I think, important for the licensee who's wanting to be a clinical provider, but I think it's really as much important to us as well, because to me it's a collaborative learning process. Yeah, I may have more experience in some areas, but we're still learning and we're still growing. So I think it's really good. And I know that for me, I don't know about for you guys, but I've certainly grown, I think, as a clinical supervisor because of that learning. So it is. And also we're preparing people to go out and practice independently. We're putting that stamp on there that says, yep, I think this person's ready for independent practice. And that's a big deal, because folks will certainly maybe work as part of agencies and do that, but some people will go hang out their own shingle and do that. So we want to prepare them the best that we can do for what that practice looks like. But for some other folks, we may want to say, oh, we got to pull back the reins a little bit. You need a little more time before you're ready for that level of practice. And that's probably the most uncomfortable part of supervision, which I'll get to. There's the reason this gets so complicated is when we think about ethics, policy, and law, they don't always play in the sandbox very well together. Sometimes they do. Sometimes it's very easy. We see the blend and we're like, okay. Other times it's like, well, this isn't really an ethical issue, but it's more of maybe an agency policy issue or law. So I think that's part of what makes this difficult for us to navigate, is that we're constantly looking at what's going on and trying to help our supervisee. The other part of this I think that can be difficult is that when you work in the same agency, there's some benefits to that. I mean, you certainly get in the day to day. You have probably easier access to that person. But when you don't work in the same agency, that can create some real hurdles as well. So, we have to kind of learn a little bit about, the agency that they're working at and, the policies that they have to operate under. Because what we don't want to do is advise our supervisees in a negative way. I think I talked about this later. I'm going to say it now just in case I didn't. But one of the problems I'm usually very careful about who I choose to supervise for lots of reasons. But I went to supervise a person that didn't work in the same agency. And I had to really negotiate with the agency to let them, so I could have access and look at progress notes, treatment plans, things like that. Not to sign off on them for billing, but just to understand that piece of practice for the person I'm supervising. How are they writing their notes? What's the content look like? So it was coming down to where, had they not agreed, I would have had to withdraw from supervision because I think that's important. Now that's again an individual call. So we know we have to do this. We know we have the code of ethics. That means staying current. When there are changes, we had a big one in 2017. We had a more minor revision in 2021. But also that our supervisees have read it and make some reference to it. We don't have to memorize it. It's online. That's where the internet's our friend. But we do need to refer back because most of us probably know this as well. There's always gray areas. There's very few times when it's this total like, oh, this is right or this is wrong. So I'm constantly looking back and saying, okay, what is the context of what's going on and what's the thing in question. The other thing, and I really like this component, this standards for technology and social work practice. One of the things I like about it gives us really specific recommendations for managing technology and ethics and practice. So if you haven't had an opportunity to look at it, it's a pretty decent document. I would encourage you to do that because it certainly gives us things that's like, oh, didn't really think about that. Because, we all know as practicing social workers, our code of ethics is written for all levels of practice. When you think about like licensed psychologists and licensed counselors, theirs is written for master's and doctoral level practice only, direct practice, clinical practice. So ours is not. So we have to get really good at navigating all of that. Let's see. Oh, okay, that's that. Okay. All right. So let me just open this up for just a second. I mean, for those of you that are either providing clinical supervision now or are thinking about doing it, what are some of the concerns you have, ethical concerns or other concerns about providing clinical supervision? Okay, no.
One of the questions that often comes up is liability. If there's a bad outcome with an individual's patient who I supervise, what is the supervisor's liability?
Okay. And Laura, I will touch on that because that is a concern, absolutely. And that's why it's so different than just regular license supervision, is we are assuming responsibility. Mm-hmm. Okay.
So Robbin, there's a few comments in the chat. I don't know if you can see it. Okay. Somebody mentioned concerns about their license being impacted.
Mm-hmm. Yes. Okay, so let me go up a little bit. Yes. So yeah, Laura, license, absolutely. Because again, we're basically, even though they're not billing under us, as we'll see later, they are practicing under us. And there's some concerns with that when we aren't always able to meet in person. Erin, and what that could mean, one of the nice things is that came out of COVID, if we can say that, is we can use meetings like this. We can use Zoom. So it does require some creativity though. I mean, so when we're thinking about, reviewing again notes, how, and thinking about what that looks like, that they bring them up on screen, that we're using HIPAA compliant technologies to do those meetings, and not just using just any technology. There may be times when it's a decision to do it as a hybrid, where maybe after so many meetings, we make a point to meet with them in their physical location. So I would say all this comes into play when we're thinking about who are we going to accept for clinical supervision. We need to think about it. So yeah. And concern my employer asked me to supervise someone I've never met or worked with. Oh, okay, Diana, yeah. Boy, that's difficult. Because do you have the right to say no? You do. Is it going to go over well with your employer? No. But I think it's worth expressing those concerns to say, let me meet with them a little bit and see. And I would hope that your employer is like, well, okay, let's see what that's like. Because I don't want to say this and come off as callous, but for employers, there's a real benefit, because the minute you start supervising, they're billing under you. So they're generating that revenue. And it's a way to get them licensed as well. So they may or may not really be thinking about the other things that come with it. They're just like, well, you're just supervising them. Well, it's not just supervising them. Okay. And yeah, it could be, departments that they may work in. Yeah. Okay. Thank you, guys. So I'm not going to read through these, but I want us to think about, even though these are written under, like especially payment for services, it's written under our commitment to clients. But because our code doesn't talk a whole lot about clinical supervision at all, I think one of the things we need to think about is fees. There is no standard on what that looks like. I've heard lots of wild things, all the way from free to several $100s per hour. And I don't think the state is going to get into determining what fees look like. So I think it falls on us to be thinking about, okay, if I'm going to charge a fee, which I have no problem with, I know, because you are giving your time, I get that. But I think we need to be thinking about the long term. Can this person pay that fee for the next minimally 2 years? Because if we don't have that discussion with them and they can't, I think that's not so great on our part. So I think it looks at, what are we going to charge? Is that reasonable for them? Now, I know things can happen that are unforeseen. I get that. And if you guys want to, put this in the chat, you can, or you can just speak it out. Just kind of maybe what you paid for clinical supervision if you had to pay for it. Because again, I've heard some incredible numbers. Because we are basically we're providing 4 hours of supervision a month if somebody's working full time, at least 4 hours a month for 2 years. So I think we need to make sure that they are reasonable, that we can look around and say, okay, what are people charging? What's that look like? And then have that discussion with the supervisee about how reasonable. Maybe their agency is going to pay for it, but what happens if they leave that agency? So I think, again, and I'm going to talk later about doing a contract, which is something I've now learned that I should have done a long time ago, and I didn't. That's part of the stuff that should go in there. So I'm getting people say $50 an hour till I moved somewhere else and it was free. Important to give back to the profession, not charge. I don't charge for supervision. Okay. Yeah. So it really depends. Again, it's okay to do it. I tend to lean on that. If I do it for free for the most part. Now I've had one agency, it was an external agency, the agency paid me directly. And my employer would compensate my time. They would generally pay me whatever my hourly wage was, but I do it for free. I've just finished with 2, and I've got 2 others that I'm not charging. So it really just depends, but I'm asking you to think about what's fair, what's reasonable, what's commensurate with the service. We know about confidentiality, again, that this stuff is confidential, and that's why you've got to use HIPAA compliant technologies, because they are talking about cases, they're talking about people's names. We are seeing notes. So it is really something we need to be thinking about that way. Sexual relationships, sexual harassment, goes without saying, again, we don't. And here's the reason that we need to look at it is this is a hierarchical relationship. We are supervising somebody and we have power over that person. So just because we're all adults does not mean that's okay. I think it's the power differential that makes it an issue. Just like for those of us in higher ed now, I mean, just because we have an adult student who it may even be older than we are, there's a power differential there. So it's just not a good dynamic. Well, harassment doesn't matter about age anyway. It's just we shouldn't. By the same token, if you have had a personal, intimate, any kind of relationship with a person, and and they want you to supervise them, you probably again shouldn't, because again, it's just a different dynamic. I'm not saying you absolutely can't, but I would encourage you to really think about that in terms of how this might not be great. But I'm not a pessimist, but I'm like, okay, how could this go bad? And that helps me in my decision making to think ahead, because it's easy to think about, well, this will be great. That person can get licensed. They can do it. Well, but how can it go bad? The impairment, incompetence, and unethical conduct. And I'm going to group those together because we are supervising. It's now not just a peer that we're talking about. We now have responsibilities to look at this kind of thing. So let's say you have a supervisee who's going through some interpersonal stuff and just not in a good headspace. We may have to say to them, look, I'm recommending that you do A, B, or C. Because we shouldn't, but we can't let them be practicing and not at a good place, because it's very easy for us to harm clients, just from that perspective. When we're not functioning well, we're not doing our clients any service at all. And this has been recommended in some of the, in doing some of the contract stuff, is that, you need to be documenting that. So if I recommend, and I'm going to pick on Mary because she's in front of me here. Let's say I'm supervising Mary and she's, I've got concerns with Mary. Here's what I think you need to do. Here's the steps A, B, C, D. I need to document that. And then if she doesn't, then we can have one other conversation, but then there might be a decision all about, do I continue to supervise Mary? And do I need to, and well, probably not do I need to. I need to go to the board and say, I've had real concerns. Mary and I have had a conversation. We had a corrective plan. That's not happened. And I know that's the yucky part about it, but we're ultimately protecting clients when we do this. We have to. That's again part of this charge. The same with incompetence. If let's say that you're supervising someone and they're not trying to be incompetent, but their agency is asking them to do things that they're not trained to do. We may have to help intervene with them. I'm not saying intervene, without them, but that's not great. So maybe they need more training. Maybe they need more time to learn. So Misty, how often the conversations take place? And are you talking about, again, impairment stuff specifically? Let me just leave the chat. That way I can keep it running. There we go. Well, I was going to talk about this later, but I can't, I don't have the numbers, but what I can tell you is now every state publishes what I call a naughty list for anybody that has an ethical complaint. And some of them make me scratch my head. They should be the things that in my head, I'm like, that should be a no-brainer. You just don't do that. I don't know what the numbers would look like. So it'd be interesting to look at, but I really don't know. But I know there's some things that, I can understand how some ethical decisions can be a little tough. I can get that. But then there's some like exploiting clients, sexual relationships with clients. I'm like, no, those are absolutely, I mean, I don't know why it just doesn't say a big NO in the code and that's all you need to say. No, you don't do it. So I don't know. But I know there's some things in there that really bother me. I'm just like, how in the world? And I know that there's a lot of stuff been written about, the whole wounded healers and how that, a lot of folks are drawn to the helping professions, and I get that. So sometimes what happens is people come into this profession with great intentions, but they're not doing their own work. And they don't realize that they're impaired and that they're crossing some lines. So again, I think it falls on us to say that, to talk about that. And again, I know that's not very comfortable, but we have to. And I think we can do it not in a gotcha kind of way, but in a very kind of caring kind of way to say, here's what I'm concerned about. The same with unethical conduct. I mean, I think our first thing is to say, let's see if there's corrective action. I don't think everything has to go straight to the board. I mean, we try to do that. What is the corrective action when it's possible? Now, if a client's harmed, that kind of, you don't pass go. But sometimes, again, people don't know what they don't know. So it's our job to do that educating stuff. The 301 talks about supervision and consultation a bit. Now it's again talking about generally. The only thing I would point out here, you guys can look at the rest of it, is, you're going to be potentially asked by somebody to supervise them, and maybe you don't have the training you need to do that. So sometimes we need to say no. And that's tough because, they might make a case for, well, I can't find anybody and I really need to do that. But we have a responsibility to practice within our scope and with our training as well. So just be, thinking, kind of about that as you get requests to do supervision. Okay. Again, and I talked about this already, impairment. Oh, it didn't change. There we go. Now, performance evaluation, that's not something that's been formalized yet, but I think there has been some discussions about maybe putting some more evaluative stuff in with supervision, that maybe every 6 months we do a kind of an evaluation to see how they're doing, and not just are they, aren't they, but rating them. I think it's Kentucky or Virginia, one of them, and it doesn't come to mind right now. They actually do a 6-month review, and they have different categories, and you rate it on a Likert scale of where they are. And I like that idea. So that way we don't get to the end of 2 years and go, yeah, I don't think you're ready. Because I don't think that's fair either. We need to be saying this stuff and documenting it as we go, so that person knows exactly where they are. The other stuff, again, you guys can look at. The thing I would say here is, one, our own impairment, if we're doing that, that we need to be taking care of ourselves through the process and whatever we need to do. But the last thing, as much as we don't like to think so, we are gatekeeping. If somebody really is not in a good place to be practicing independently, then we shouldn't say that they are. Because again, you're putting your name on it. You're putting your stamp on there. And I don't say that that's something we should do lightly, but it could be a situation where, they're just not. Whatever the thing is, they're not grasping the concepts of whether it's diagnosing, documenting, the interventions, whatever it is, or maybe it is ethical practice. They're just not making great ethical decisions. I don't have it on here. I don't think. There's a really good website. It's actually from a business school, and they talk about different kinds of things that get us kind of in a mess ethically. And one of them is ethical fading, where we just don't see. But I think those are good. I need to put it in this presentation. That how people get into trouble that they do. So, again, as supervisors, I think when we see thinking that's off, or we see somebody that's maybe operating from their own personal lens versus the professional lens, we need to be able to say to them, okay, wait a minute, but let's think about this differently. Or if it's so bad, we might have to say, I'm worried that you're not looking at this from a professional standpoint, you're looking at from a personal standpoint. And that concerns me, and here's why. Okay. So again, we are gatekeeping. I don't know how many times that somebody has not been recommended to go forward after that 2 years of supervision. But I imagine it can happen. Okay. Another thing, and this is where sometimes ethics and law play well in the same sandbox. Sometimes as the code of ethics is updated, it's because there's been new law, new litigation. We know Tarasoff happened, years ago, and with mandated reporting, and it should have. And it actually is in our West Virginia code as well. So when somebody is threatened to kill themselves or someone else, the abuse and neglect of child or incapacitated adult, we are mandated reporters. So that making sure that our supervisees know that. And so if you're talking about that during supervision and they say, okay, I'm going to make that report, I would follow up to say, Okay, who did you talk to? When did you make it? Because what if they didn't? What if they said, well, I don't really believe it? Again, not for us to believe, it's for it to be investigated. Confidentiality, again, is in our code, it's in the West Virginia Code. Now, this is where it gets a little murky, because in section 3030, which is social for social workers, it talks about privileged communication, but we do not have privileged communication. So even though it uses that term, that doesn't fly in courts. So we can't claim it unless you're a clinical social worker involved in a federal case. Then you have privileged communications. It's recognized at that level. So, if you have a supervisee who has been subpoenaed to court, we might need to help them figure out, how to navigate that. One, checking that what do they bring records? If the records weren't asked for, they probably shouldn't bring them, because then they can issue a kind of a bench order right there. It might mean that they need legal counsel if their agency or your agency doesn't have legal counsel. There's all kinds of things that kind of come into play here. So, again, just because it's mentioned, we don't, and I think that's one of the things we need to realize that needs to be part of that spiel to clients about confidentiality and the exceptions is, I have to report all of these things, but also understand if I get a court order, I don't have the ability to not show up and testify. Under HIPAA, and that changed the world a bit too. So, confidentiality has been in place for a long time. HIPAA just kind of up the standards a little bit. So it's how data is protected. And this is where, again, it goes back to, if you're supervising, what means are you using to do that supervision? I would not, this is me personally, I would not ask that person to send me stuff back and forth through the mail with client information on it. So it goes back to, what if you can't always meet face to face? That might be a decision to where you say, okay, I can't, I'm not going to do this. I can't do it. But also I would go further. I think, I don't know what you all feel about this. People have gotten a bit lax about where we are when we communicate. So where is your supervisee when you're having these supervision sessions? How are they assuring for privacy? Where are you? How are you assuring for privacy? Because people can get a bit lax, and that's stuff, again, we need to talk about, and that can actually go into a contract that you draw up with them to say, here's where supervision needs to take place if we're going to do it electronically. So again, it's on us to figure out the technology. So that might mean either your agency purchases a HIPAA compliant technology, or if you're doing it independently, that you're doing it, you're purchasing it. We know about mandatory reporting as well, that for adult and child welfare situations, so that is exclusion for confidentiality. So again, if our supervisee says, hey, I've got an older client and they told me today that their son or daughter is taking advantage and taking all their money, and then that may trigger a report, and they need to do that. It could be, again, a child welfare thing. The other thing that gets slipped by sometimes, if you don't go back and look at the code, there are circumstances where we not just notify DHHR, we also have to notify the police. And our supervisees may not know that. We may not have known that. But so we have to look at things like that. We have to be kind of aware of who needs to be notified. If it's bad enough, they may need to call the police and the hotline. And again, documenting that they did it and who they talked to. The social work practice stuff is all under section 3030 of the code. And I don't know about you all, when I look at it, it makes my head hurt sometimes. Yeah. And then, again, confidentiality is in there. Copies of healthcare records. And what's interesting about that one, for those of us that are working in mental health, you do not have to turn over the record to the client. You have to provide them a summary. You have to be available to review the record with them, but it's not the same. Mental health records are treated differently than medical records. So just be aware of that. So again, if your supervisee says, hey, my person came in today and they wanted a copy of the record, and I copied and gave it to them, and it's got all this substance use information in it and all this stuff, that's not probably what they should have done. So That section of the code will take you there as well. Okay. Can you all think of any other kind of legal considerations we need to be thinking about in doing the supervision stuff?
Robin, can you comment a little bit on, well, somebody just posted in the chat too, but I'm wondering about what are some specific examples of times when we might need to contact the police or other authorities?
Yeah, usually it's if there's been any kind of physical harm or sexual assault, those generally should go to the police as well. Okay. Guardianship, Missy, thank you. That's a good question. Too. Here's the thing. We need verification of who's got custody and guardianship. You can have a parent bring a child in and they say, hey, I have legal guardianship, or I'm the legal parent. Maybe they're not. So, I mean, that's something we have to make sure that we get. And so they need to bring in whatever court orders that they have that says, here's the decision making. Because it also may be a situation where, yes, that person has primary care, but the other parent is entitled to know what's going on with that child and what services they're getting or are going to get and things like that. Missy, does that kind of answer that a little bit? Okay. Yeah, what I would tell you, going back to what Mary asked about, when you go back, especially if you look under those 49.2 and 9.6, you can go under there and it will tell you a little bit more about when you probably should. But what I would say is if somebody is in any kind of physical danger at all, then probably the police need to be involved. And you can't really go wrong that way. You're protected if you do that. But that does not negate also making a referral to CPS or APS. One does not negate the other. So I would again say, as a supervisor, go look at those sections and kind of get an idea of what you want to do. Treatment for minors who can consent. Again, do you mean because they are now oh gosh, the word just popped out of my head. Emancipated, or what do you mean? Okay. Now this is where I'm a little gray on this one. It used to be that they could consent to substance use treatment. Is that still true? Because my understanding is the parent or guardian still needs to consent. Anybody know? Okay. Yeah, that's gone back and forth and changed, but for me, and I don't do substance use treatment. I'd have to go ask somebody about that one. But my understanding with regular mental health treatment, you still had to have parental consent. I mean, a child could refuse to cooperate and want to be in, okay, but you still have to have consent for treatment. Okay. Okay. So when we think about telehealth, again, it can be a good thing. Zoom and I are fighting, so I'm not sure about that right now. Excuse me. One of the things I would tell you is, first of all, within our state, we can use it. If you're going to supervise somebody from another state, you need to first check with that jurisdiction. Oh, okay, Diane, I'll get right back to that. So if, let's say I have somebody asked me to supervise them in Bluefield, Virginia, right across the border, I still need to get in touch with the Virginia Board of Social Work and make sure that's okay. And sorry, if they say yes, then okay. But you can't just do it just because. Okay. The other thing, same thing with practice, if you're going to practice. So you want to, you have to, if let's say you're seeing a client and they move, you have to make sure it's okay for you to do that. Sorry, recovering from a cold. So I would just say, I should put that first. Always start with the licensing board. So if you're supervising and your person's going to move to Missouri, I would get in touch with the Missouri board and see what their requirements are. Okay. Thanks, Laura, on that. Okay. There was a question about parents believe they have the right to information. Well, I guess ultimately they do, but that's again a conversation you have right off the point is if I'm going to see your child, understand that there's some things I'm not going to tell you because they're entitled to confidentiality. But also, if there's any concerns of safety, I will absolutely tell you. And, maybe the parent's not going to agree to that. Then you have a decision to make about treatment. Okay. So in the chat, I will look up this later. So Misty said in West Virginia for mental health treatment, a child who's 14 may sign their involuntary treatment. I don't know what that means legally. And then Laura posted out, and I will look at that later about pediatric stuff. It's just this is where it gets, I think, again, gray and vague. Because certain programs they can do, certain ones they can't. So I would say you have that one. I can't tell you. I don't know. I would say if you work for an agency that has legal counsel, I would ask. I don't know if MSW, their legal counsel, their folks can give you some guidance as well, but that's a possibility. Okay. Again, we know what telehealth is. So can you just do supervision by phone? You could. But again, my question would be, how is that going to be different than, and how are you going to see what they're doing in terms of, again, their documentation, things like that. Excuse me one more time, sorry. So I'd say, think about how you want to use telehealth. I'm sorry, give me 1 second.
So while Robbin, I was just looking through the article that Laura posted, and it looks like minors can consent to mental health services if they're 14 or older in West Virginia, but substance abuse at any age. Is that what you were seeing, Laura, in there too?
I did not read the whole article, but it looked like it went through state by state so that people could look that up.
There's a table. So I was scrolling through the table and looked for West Virginia. It has all the different. So anyway, the link is in the chat if folks want to take a look. It's interesting.
Yeah, I'm gonna pull that up later too, because it's just been what I don't. So again, just with telehealth, again, we can, in order to do telehealth, you have to be a clinical provider. So that's the level you have to be at. So let's say that you have somebody contacting you from another state who wants to provide clinical services here, and they're not a clinical social worker. I don't think our board will allow it, even though they're under your supervision. So that again, you would check with our own board. I know that our social work board gets questions from people wanting to provide services from out of state. And if they meet all the requirements for here, then they allow it. If they don't, they don't. The other thing is, and I know we've gained some knowledge through COVID, but that we just try to keep our knowledge up about using telehealth. It's a different beast in terms of, seeing somebody in the same office. If you're involved with, so let's say you've got your supervisee is using telehealth. Are they doing some of these things? Are they verifying where the person is when they start their session? Are they making an attempt to understand what privacy the person's putting in place? Have they done anything to say, is telehealth even appropriate for the clientele? Because one of the things, I don't know if you all heard this, it concerns me, is people are like, oh, I love telehealth. I don't think I want to go back to face-to-face. Well, just because it's convenient for us does not mean it's the best for our clients. So I think we have to be mindful of, is it really best? So these are just some things to be thinking about, talking to our supervisees about, well, our own practice, but also supervisees. Again, I've had to stop a session. I do a little bit of counseling on campus where I've had a student that was, they logged into their session. They're in a car with other people. I'm like, we can't do this right now. This is not happening. Or walking through the store, or, in the middle of the living room. I'm like, we can't do this. Because even the client may not be thinking much about the privacy stuff, but we need to be thinking about it. Okay. So a little bit about, and I'm going to get to questions. Professional liability. When you assume clinical supervision, you are assuming direct liability and one of the things I don't like about it is when that person is held to your standard of practice. This is why this is such a big deal, and I think people should not have tons of supervisees. I think it's very labor intensive, and I think it's very legal intensive. So when if you are supervising them, and let's say they're making mistakes, and there's no corrective plan, I think somebody would say, why not? Why is that not present? Okay, so it's something to think about, liability. Can you show that you have the knowledge? One person I'm supervising is also getting certified in trauma-focused CBT. It's not an area of specialty for me, so she's getting separate supervision for that. I'm supervising her for the other practice areas that she's doing. So there may be a shared supervision in some ways. And so I think, again, this is where the contract stuff comes into place. We really spell things out. So direct liability is you provide bad guidance. And indirect is when they do something, but yet it's under you. So if this is why I think we need a lot of eyes and hands on to know what that person's doing. And I think for me, why I'm so cautious about who I will take on for supervision. Not because they're not a good person, but I need to know, what are they doing? How are they practicing? Because my license is on the line. Okay. I'm not going to go through all these. These are in the PowerPoint. You guys can have them. But again, I would encourage you guys, this is late learning for me. I would do you get a little contract through the state. I would do a separate supervision contract. And there's lots of examples online, excuse me, where you can spell them out as clearly as you want, from fees to when you will meet, how you will meet, their responsibilities, your responsibilities. I'll spell it out as clearly as you can. You might get somebody who hit and misses. They come to supervision, they miss a couple. They come, they miss. Still doesn't mean you're not responsible for their practice. So that might be part of your contract where you say, if you don't keep your supervision appointments, this is the next conversation we have. Again, the length, frequency, and duration. Now you can meet. You can meet weekly if you like for an hour. You can meet every 2 weeks for 2 hours. There's a lot of variability in what that can look like. So again, that would be something you would talk about. Yeah, I was going back to practice. Thanks, Dina. The licensing board allow practice within the jurisdiction except for emergencies, but you can contact, if you have somebody, you definitely want to contact the other board. I had a student who moved to Pennsylvania, and I contacted the board there, and they allowed me to see just that person in Pennsylvania. That's it. But they wanted my license, they wanted my malpractice insurance, they wanted some information first. Okay. So these are just some tips for what to maybe put in a contract. Okay. Again, just how they're documenting, that we know enough about what they're doing. And this goes back to a question earlier. What if you don't know the person? Then you might want to have some pause before you say yes. about supervising. Okay. Your own liability insurance, make sure you have your own. Your agency may have it, but you need to, one, make sure what kind of policy it is. I would recommend get your own, because that's going to protect you, but also make sure what your liability insurance says you can and cannot do. Maybe they say you can supervise, maybe they say you can't. But make sure before you jump into this. Mine have always been okay with doing supervision, but one of the weird things, mine would not let me serve on a board of directors. I was not covered. So make sure you know what your insurance covers and that you're okay. Okay. So I'm going to stop there. There's lots of stuff. I know we went fast, but I want to leave about 10 minutes or so for questions. I'm sorry for the voice stuff. Okay. Questions, comments?
I have a question while people might be typing in the chat. So when you say you sort of want to know how they're practicing, how do you gather that information if you're not affiliated with the agency that they are working in?
That's a good question. That's tough. I think the person I did external, most of mine have been, well, now, no, a couple of them are external now, is I met with them and their direct supervisor to really know a lot about their duties. I want to look at their documentation, because ultimately, if they're not in the same agency, but even if they are in the same agency, unless I'm sitting in with them, I don't know for sure. So part of it, I think, is a little bit of a gut thing, but also I think looking at, when they can tell you, okay, I'm providing this kind of treatment. If they can't tell me about the treatment they're providing, that's not a good sign. If they're saying, oh, I'm doing CBT treatment, okay, tell me about that. Tell me how you're using it. What does that look like? And if they can't, then maybe they're not doing CBT treatment. Or if they say to me, I'm doing EMDR, are you trained in that? Tell me about the training you've had. How much training? Because so I think the best we can do, Mary, is just ask questions to give us the best picture of it that we can, because ultimately we don't know. We really don't. Could you check in, and this, I think if you were going to do this, it needs to go in your contract. Could you check in with their agency administrators and stuff? I think you could, but I'd want to make that clear up front. What do their performance evaluations look like? Are there any concerns that their direct supervisor or their administrative supervisor has? So I think we could employ that as well, but I think we want to spell that out up front, if that makes sense. But it's hard. I think that's always my kind of my anxieties about, I need to know something about that person, and I need to feel comfortable about what they're doing. Not aware. Yeah. The insurance, when I called them, they were like, no, we don't cover you to serve on a board. Now, I'm not saying they all do that, but mine would not allow it. There's a survey in there, guys, too. Make sure you do that. But one of the things I tell you, there's lots of, you can look up and you can tweak them. That's the nice thing when you're developing your own contract. You do the one that the state asks you to do, but you can make your contract as specific as you need it to be. So, you can pull from different ones and say, okay, I want these elements in there, so that, I know what's expected. My supervisee knows what's expected, and there's no question at all. Because like I said, that was probably my biggest learning. My other biggest learning thing is really taking into account what's the person's learning style and what's my supervision style. Maybe I need somebody who's more hands-on, that they need somebody who's more directive. And if I can't be that person because I don't like being directive, then maybe we're not a good fit. Can we handle things like when there might be pushback? Maybe you have a supervisor who maybe is getting defensive, and how are we handling that with them? So there's a lot to think about. So there's some good stuff written out there. Like I said, hopefully when we get this manual, it should be in the spring. That will help some, because we'll have the process of it, but we'll also have some supervision tips, some example contracts and things like that for folks to use. So it is coming. We're getting there, just we're not there yet. But other than that, any final questions?
Thank you, Robin. This was a great presentation.
Mhm.
Really, really interesting and informative.
Yeah.
Thank you.
And I will tell you, we do from time to time, and you can take them. The other social work schools can do them. I don't know if they have been, but we do. I do it twice a year. We do like a 6 hour supervision training that covers a lot of like methods and other kind of the bones of it. So if you're ever interested, reach out. I'll probably do another one in the spring. I just did one that you can take even if you're already a supervisor or if you're going to get into supervision. Okay. All right. But thank you very much.
Okay. So folks, there is, I'm going to put the link to the survey in the chat one more time. If you can take a moment to finish that before you leave, that would be great. And if not, you'll get a link with your CE certificate, and appreciate everybody joining us, and hopefully we'll see you next time.